Hey everybody, it's me. So I thought maybe we would just run through some of this liver stuff that we already did last week and then wrap up what we didn't do, which it seems like we did a lot of it. And then tomorrow in class, or Tuesday, depending on when you're listening to this, in class, we're going to have 1 hour of class time to kind of conversate about this, questions, activities, things like that related to liver and pancreatic disorders. So some of this I'm going to move pretty quickly through, just kind of pulling out some of the hot topics related to stuff we. So remember, we reviewed anatomy and physiology. Liver gets 25% of cardiac output. It's very vascular. So we talk about doing biopsies. Bleeding is a really, really big thing. Also, bilirubin, clotting factors, metabolism of carbohydrates, fats, proteins, and then fat-soluble vitamins and iron as well. What are some things we're going to ask our clients about? We went through this, talking all about this. I'm not going to review this slide much. Physical assessment features: jaundice, muscle atrophy related to lack of nutrients, skin issues, scratching related to buildup of toxins, petechiae and spider angiomas related to lack of clotting factors, abdominal fluid, ascites related to backing up of fluid into the portal vein, causing portal hypertension, and ultimately causing the fluid to leak out into the belly. The liver might feel actually lumpy and bumpy and firm on patients. Their mental status can potentially be changed related to buildup of ammonia in the body and then causing altered mental status. Liver functions, we talked about these: AST, ALT, alkaline phosphatase, also, or ALK-Phos. Those are really like the three most important that from a nursing perspective, physicians and providers might look more also at GGT, GGTP, but we look most typically at AST, ALT, and ALK-Phos. Serum protein studies might be altered. Bilirubin, ammonia, and prothrombin times all might be altered when we have liver dysfunction. Liver biopsy, remember pre-procedure, we're thinking about things like consent, patient's mental status. Are they confused? Will we need to hold them down for this, or restrain them, or medicate them? They should have coagulation labs done beforehand. It's most typically done in interventional radiology. Intra-procedure, we're thinking most about sterile technique. Post-procedure, we are thinking about making sure they're not bleeding internally. So what position did we say we lay them in? We put them on the right side to apply pressure to that site, using the body or the weight of the body to be the pressure. Hepatic dysfunction, either acute or chronic. Cirrhosis, of course, is chronic. 12th leading cause of death in the US. That's pretty serious. 40% alcohol related. Men, twice as more common as women. Some of that is genetics, but some of that's also related to men often drink more alcohol than women do. Infection, hepatitis, which we're going to talk about and already talked about it. Anoxia, lack of blood flow. Toxins, medications, and of course liver cancer. We're going to talk about liver cancer at the end of this slide, or end of this presentation. Here's that lovely picture of poop. Remember, when patients have liver, we're talking about the clay-colored stools related to a lack of bile acids, and an amber-colored urine related to excessive bilirubin. So the stool has lack of bile acids because the liver isn't secreting the bilirubin, which breaks it down to the bile acids. So there isn't becoming bile acids then in the stool. We talked about all of these things, and we're going to talk about a lot of them on upcoming slides as well. Hepatitis is the term hepatitis in and of itself just means inflammation or infection of the liver, but viral hepatitis is most typically what we mean when we say hepatitis. A through E, I think there's even an F and a G now. So hepatitis with a vowel comes from the vowel. So thinking about the A through E, not thinking about the F and G, that still stands. B and C are bloodborne. D, only people with hepatitis B are at risk for this. And then non-viral hepatitis is toxin or drug-induced. A is the most common. A lot of us might have even had this and didn't know. Incubation period 15 to 50 days, may last 4 to 8 weeks, not chronic. It is acute in nature, hence why some people can get it and not even realize that they've had it. If they do have symptoms, they're often mild flu-like symptoms. Unless it's a very severe illness, then we might actually see signs and symptoms of liver failure like jaundice, dark urine, indigestion, or epigastric distress. What are we going to do? Good hand washing, safe water, and proper sewage. So if these patients are hospitalized, what types of contact precautions might they be on? Of course, they're going to be on gown and glove because that is what we consider contact precautions, and we don't want to spread this to the next patient. They might need bed rest for a period of time. The vaccine, of course, is great at preventing it, but once someone already has it, we're not going to vaccinate them. Immunoglobulin is different than vaccine. Immunoglobulin is something we give patients that is actual cells to fight the hepatitis or prevent the hepatitis from being contracted within their body. A vaccine, remember, we give a vaccine, it takes a while for the immune system to build up immunity. Immunoglobulin is almost like immediate immunity, or immediate ability for the immune system to at least kind of fight this better than what their immune system was equipped before giving it. That's why we might give that for close contacts, um, to help them from getting a really big infection of hepatitis A. Hepatitis B, blood, semen, saliva. We talked a lot about this. Who's at risk? IV drug users, people who engage in risky sexual behaviors, healthcare workers. Many people recover spontaneously, but 10% will go on to have chronic hepatitis B, sorry. So it is something that we want to prevent. Of course, we know there's a vaccine. It's a 3-vaccine series, although I do believe that there's a single vaccine for this that's either just come out or is kind of on the cusp of becoming maybe the standard. For now, we'll continue to know this by the 3-vaccination series, given usually at birth, a month, and then 6 to 12 months later. We can, of course, treat patients if they develop chronic hepatitis B. Usually those are antiviral agents or interferon to help the immune system fight off basically the virus, because it is a virus. Standard precautions and infection control measures, since it's a bloodborne illness, we don't really need to go above and beyond except for just standard precautions, meaning that if we anticipate that we're going to come in contact with blood or body fluids, we should protect ourselves. Hepatitis C is also very common amongst those with risky sexual behaviors, are IV drug users. Most common in that, it causes 1/3 of cases of liver cancer. So not only does it cause cirrhosis leading to liver failure, it also can go on to cause liver cancer. The most common reason for liver transplant. Incubation period is variable here. Symptoms are usually mild. Patients don't even maybe know they have it until all of a sudden they're screened and they're already considered in a chronic state of hepatitis C. Antiviral medications here. It used to be difficult to really treat hepatitis C, but we do have more treatment mechanisms now, but it requires a lot of medications, a lot of commitment to those medications. We do see some non-compliance related to side effects, so some things to think about. Alcohol potentiates the disease, so a lot of lifestyle modifications when patients get this diagnosis, as well as that of pancreatitis, because alcohol is directly causing these liver and pancreatic issues. And if it's not causing it, it's only going to make it worse. So we need to talk to them about changing their lifestyle. Other liver disorders, drug-induced hepatitis, the number one medication we mentioned was acetaminophen or Tylenol. So we have to know the regulation, 4,000 milligrams per day, but that's for short-term doses. If you're going to take it every day for months and months on end, we really need to drop that down to 2,500 milligrams, and that target is often moving. So that might change. You might hear that change. For us, we should know 4,000 milligrams a day is okay unless we're taking it all the time. than 2,500 milligrams. Or if we have known liver disorder, we shouldn't really be taking any Tylenol. Hepatic cirrhosis then really is when we get that liver tissue being replaced with the fibrous or dense tissue that disrupts the structure and the function of the liver. 3 different types: alcoholic, pretty self-explanatory. Post-necrotic is related to this hepatitis that we've been talking about, but also if there was a lack of blood flow to the liver for a period of time, we would see that having the same effect. And then biliary is like when there's a stone or something, stenosis of the common bile duct, and bile is backed up into the liver. That can ultimately lead to dysfunction and cirrhosis of the liver as well. Jaundice, we looked at this picture already. Hepatocellular jaundice is what we're talking about here when the liver doesn't work. Portal hypertension, we talked pretty lengthy about this as well. Increased pressure in this portal vein over here, which causes backup of fluid into all of these vessels behind it, including the esophageal vessels. So those vessels become enlarged and kind of outpouching, leading to esophageal varices and leading to ascites. This is the pathophys that we believe, although we don't 100% know for sure that this is how ascites works. We do feel that this is what happens. You don't need to know every step of this, but for those of you who like to know, it's there. The fluid in the belly can accumulate up to 20 liters, which certainly is going to make your patient feel short of breath. They're going to have loss of appetite because they're going to have all this bloating in their belly. Their GI system is not going to be working appropriately because of the pressure of it. And then as it gets worse, it starts to push up on the lungs and the heart as well. Record abdominal girth and daily weights is our best way to know that the ascites is getting better or worse. Monitoring their respiratory system, and then potential fluid and electrolyte imbalances can occur because fluid will be leaking into the belly. After we do something like a paracentesis, it's going to be important that we monitor for that as well. Low sodium diet of 2 grams, because we know the more salt we have, the more fluid we have. Diuretics like spironolactone, because it's not a potassium losing diuretic, so it'll help us to hold on to our potassium. Here's the paracentesis. Remember, the biggest thing we talked about was this vascular collapse occurring. So if we remove a whole bunch of fluid from the belly, we can all of a sudden have a bunch of fluid shift from the vascular system back into the belly, causing not enough fluid to be in the vascular system to maintain perfusion and normal fluid and electrolyte balance. A few days later, infection, of course, can be of concern as well. Here's the TIPS procedure. I'm not really going to review this in much detail. Again, we already did, but basically it's bypassing some of this cirrhosed liver so that fluid doesn't back up as much and cause so much of an issue with portal hypertension and esophageal varices. Here's the picture of esophageal varices, major cause of death in patients with cirrhosis, because if these varices start bleeding, it's very, very hard to control these varices and stop them from bleeding, so patients die from bleeding. What do we need to do to prevent them from bleeding? So things like no coughing, trying not to sneeze. Of course, that's not really preventable, but treating colds somewhat aggressively so that they're not doing a lot of that, not straining to move their bowels, eating soft, small meals so their belly isn't super full and pushing on it as well, and there's not like sharp or jagged food going down their esophagus that might kind of rip open these esophageal varices. How will you know if your patient starts bleeding? Blood pressure. They might start coughing because blood might be coming in there. They might feel nauseous and start vomiting. Those are going to be some of the immediate signs and symptoms. What are we going to do? We're really going to treat like it's a shock patient because they're bleeding. So we need to keep their blood pressure up, keep their volume up. We might use things like propranolol or nadolol to decrease portal pressure in combination with things like vasopressin or somatostatin to help vasoconstrict. And then octreotide is a medication that we specifically use often for GI bleeding. Again, those are not listed here on your farm objectives, but we should just know that they exist. Most typically, as from nursing perspective, we are doing things like giving IV fluid boluses, replacing electrolytes, administering oxygen, and making sure our patient maintains blood pressure, heart rate, and respiratory rate. They might emergently go in and place a tube that has a balloon to put pressure on the esophageal varices. That's a temporary fix. Or we might go in and do sclerotherapy, where they actually inject some substances to kind of build some scar tissue where those esophageal varices are. Or we might do banding. So here it kind of shows you the vessel. They can kind of suck the vessel up and put a band around it so that the varices aren't going to rupture. We already talked about this ammonia level and why these patients get confused, but what it's called is hepatic encephalopathy. They develop neuropsychiatric manifestations because of the liver's inability to detoxify byproducts of metabolism. Ammonia really is our most typical one that we talk about. When those ammonia levels become elevated, we not only see altered mental status, but we also see motor disturbances. Apraxia is here on the left, and that's where we ask them to kind of mimic a simple shape, and they can get the lines right, like they're attempting, but they just can't put it in the correct order. And then asterix is where we have the wrist, you put the arm out, you put the wrist kind of dorsiflexed up. A provider, you can push on it even more up towards the body, and when you let go, the hand flaps involuntarily. Very, very classic for liver failure and liver cirrhosis. So what do we do when we have these hepatic encephalopathy or this neuropsychiatric symptoms? We're going to try to eliminate the precipitating cause, which would be typically this ammonia level. So we'll give lactose to do that. We might give IV glucose to minimize protein catabolism, because if our body can't break down fats, proteins, and carbohydrates, we get these substances of metabolism that are hard for us to manage. So the glucose can help with that. Protein restriction, reduction of ammonia from the GI tract, discontinue sedative analgesics and tranquilizers, because all of those will build up in a patient whose liver isn't breaking down medications appropriately and only lead to further neuropsychiatric symptoms. Here's some diagnoses. Tomorrow or Tuesday, we're going to work through some of these and do some care planning and really talk about the care of the patient. So I'm going to skip over these next few slides because I think we'll address this in class. Let's just wrap this quick little summary up with a discussion of liver cancer. So it can either be a primary tumor of the liver or it can be metastases. So not very many cancers actually start in the liver, but a lot metastasize there. But we do have this hepatocellular carcinoma, which is often associated with chronic hepatitis B and hepatitis. So what do these patients complain of? Dull, persistent pain in the right upper quadrant, back, or epigastrium. Typical signs of cancer, things like weight loss, anemia, anorexia, weakness. And then on top of it, things that are going to more push us to believe it's liver is things like jaundice. We have occluded bile ducts related to the tumor, then get ascites and obstructed portal veins. So all of that is really related to the liver tumor itself, where it is located in the liver, and what is it pushing on? Is it pushing on a specific bile duct? Is it pushing on the portal vein? What is it doing, and what kind of damage is it causing in the liver? As the tumor enlarges and uncovers, in cases a lot of the liver in and of itself, then we will see signs and symptoms of cirrhosis or liver failure. Non-surgical management. Underlying cirrhosis, which is prevalent in patients with liver cancer, increases the risk of surgery. So we have to also then think about non-surgical options. Most of the time, this means it's palliative care, right? Helping them to have as long of a life that's good quality of life. We might do radiation, we might do chemo, we might put in a percutaneous biliary drain so that the liver can kind of continue to drain and not back up into the liver, that's something that they would then keep, right? Because we're not fixing it, we're not taking the liver out, we're not resecting it. That would just stay in until end of life and be, again, a palliative treatment. Surgical management, which of course is the treatment of choice, if the hepatic carcinoma is confined to one lobe and liver function is still adequate. The liver does have regenerative capacity, so we can take off part of the liver, which would be a lobectomy, or we can do complete removal of the liver and do a liver transplant. Those are really the two different surgical. So it's used to treat life-threatening end-stage liver disease, just like we talk about end-stage renal disease, we talk about end-stage liver disease. We either take the entire liver, usually from a cadaver donor, or the right lobe from a living donor. So we can actually take in a live patient, resect out part of their liver, give it to somebody else, and both of those livers will regenerate back up to capacity. Success of transplant, just like with any transplant, is mostly dependent on immunosuppression, how the patients tolerate the liver, how they tolerate those immunosuppressive agents. And then long-standing systemic problems complicate care. So the more chronic illnesses we have, the more their bodies had to tolerate chronic illness, the more likely they are to have complications post-transplant. This is kind of just a picture here of what it might look like. Of course, this would be a very, very involved procedure. These patients would need a lot of care. They'd have a lot of drains post-operatively. They would be in the hospital for quite a while they recovered, and hopefully we were able to see their liver functioning properly. So nursing care, what are we most worried about? Well, bleeding, infection, and rejection, right? So hemodynamic stability right after surgery and that little bit of time. The liver plays a big role in clotting, we know, so bleeding is going to be even more of a potential for these clients. Infection related to number one, surgery, number two, they're on immunosuppressant agents kind of right out of the gate, and then rejection. Ethical dilemma, why? So I'll leave you thinking about that until we talk about it in class. We can talk more about why is there ethical considerations related to liver transplantation.